Very good morning, everybody. I'm very happy to welcome you all on behalf of Director NAAB and the Scientific Events Committee, which manages all the events in NAAB. I hereby welcome you all to special lecture by Dr. Chandrakant Lahariya on the World One Health Day. Welcome, sir. One Health Day is observed annually on the 3rd of November every year to raise the global awareness for the importance of One Health collaborations. This day serves as a platform to enhance the understanding of One Health approach, to garner the support for its practical implementation, and to promote the best practices across all sectors, to involve all the key stakeholders as well as the policymakers who have the pivotal role in advancing the public health and mitigating the emergence of any new threat that we recently saw in the form of pandemic. So, as all of you know about a story which I would like to tell today in the morning, you remember the father who taught his sons to be together. So, what he did, he gave one stick to every of his sons and then asked them to break it. They were very easily able to break it. But then, when he handed over a bunch of sticks tied together, the sons were not able to break it, and they learned a very good lesson that they'll have to be united together and act together. So, the theme for this year is Act Together for One Health. May I invite our director, Dr. G. Karu Sharma, to give a welcome speech. Thank you.
Thank you very much, Dr. Madhuri. She already set a stage for the day before we hear the lecture. Very good morning to one and all. Most welcome, Dr. Chandrakant Lahariya, for making to be amongst us, Neabians, and giving a lecture on the theme which Madhuri has already detailed at the beginning. I must share with our group, a couple of my scientific colleagues know, Dr. Chandrakant Lahariya is basically, everyone must have by now understood, but just now I came to know, he says that he is on sabbatical from WHO, and he is actually a founding director of Foundation for People-Centric Health Systems. It's pretty much accomplished person. Sonu is going to detail out what exactly he is. Besides, a couple of us must be reading his editorials, and not only during COVID times, and now also. And he's been very generous and kind to give us his book as well. So he's given me 2 books. So one would surely be kept in our library. Thank you for that. And I just thought that there were a couple of options, but when I approached him, it was very difficult for him. It was election time for WHO 2 days back, and he was very busy. And today there's a specific meeting, and he was involved with that. So somehow we negotiated that he would be with us on 2nd of November, evening of 2nd November, and we loved it. But as it happens sometimes when you are handling important things, and you are a person who do it with passion towards One Health and your core area. The same thing must have happened with you, Dr. Lahariya. And I was kind of given a feeling it is not possible for him to be here, so we will have him virtually. But to cut the story short, and somehow he rescheduled, and made it on 3rd. I have no words to thank you for that. And we all, including me myself, look forward for the talk and further interactions with the group of scientists who are here, and our students who are ever keen on interacting with the speaker. With that, I welcome one and all, and best wishes and congratulations on this important day of World One Health Day. Thank you so much.
So good morning, all. So it is my great pleasure to stand before you all today to introduce Dr. Chandrakant, who is known for his remarkable contributions in the field of public health and epidemiology. He is a notable Indian medical doctor known for his significant contributions in the field of public health, infectious diseases, preventive medicine, vaccines, and immunization. He has extensive experience in child health, school health, early childhood development, preterm and stillbirths. He is founder director of Foundation for People-Centric Health Systems, New Delhi, and regional counselor for Southeast Asia section of the International Epidemiological Association. In early 2008, Dr. Chandrakant joined the World Health Organization in India, where he coordinated the organization's work on the new vaccine introduction in the country. Dr. Lahariya has 15 plus years of work experience at international level with World Health Organization in India, in Africa, and the headquarters in Geneva, as well as with the UNICEF and the World Bank. In recognition of his outstanding contributions, Dr. Chandrakant has received several prestigious awards, including the ICMR's Dr. V.C. Srivastava Foundation Award in 2012 for his work on translating community-based health research into public policy interventions, Double Helical National Health Award for COVID-19 work in 2022. He is one of the lead co-author of the best-selling book entitled as Till We Win India's Fight Against the COVID-19 Pandemic. His dedication to promoting evidence-based healthcare and effective health policies has garnered recognition and respect in both academic and public health communities. Today, today's gathering is a testament to the admiration, respect, and gratitude that Dr. Chandrakant's work has garnered from all corners of the public health communities around the world and beyond. We are honored to have him in our midst and we eagerly anticipate the insights that he will share with us today. So let us join hands in welcoming Dr. Chandrakant with utmost enthusiasm and appreciation. Thank you. Yeah, yes. I invite you, sir.
Good morning and thank you very much. It's indeed a pleasure and honor to be here. And I must thank Dr. G. Taru Sharma for her perseverance and insisting that I should come here. And finally, I'm here. Thanks to the scientific committee for planning this lecture. So I'm really pleased, honored, and thankful in one single breath. Coming about the theme of the day or coming about the topic of this lecture, One Health. I must say that I have worked with WHO for 15 years, nearly 15 years. And one of my role was organizing World Health Day, which is on 7th April. So I've done that a long time. This is my first major event around One Health Day. And I'm really happy for that, today I'm talking about One Health rather than only Health Day. So this is what I plan to do in next 30 to 45 minutes, and then we might have an interaction. That I'll lay down the theory theory of One Health, that why One Health is relevant, some historical evolution, and also then we will talk about what is happening around the world and India about One Health. Now, I would not claim that I am going to say anything which is around. Rather, this is a presentation to all of us together start thinking in that direction. What we know, what should be done. So it's a presentation for thinking. It's a talk for thinking and understanding. And with that, I've put this topic or theme of the title of this presentation, One Health, Need for More, Better, and Together. And that's how it can be done. when we talk about One Health, and of course, this One Health concept is relatively new, but not very new. Like in the last 10 or 15 years, we are hearing a lot. But the relevance of One Health has become even bigger or higher with the COVID-19 pandemic, which is just behind us. What we know that the pandemics were being talked always, and pandemics has happened since ancient times till today. What we also know that though outbreaks and epidemics are more frequent, keep happening. Like in fact, if we talk when we are sitting or standing in this room, even today in different parts of the world, small outbreaks. They could be outbreak due to a waterborne disease, outbreak due to different small viruses. But outbreaks and epidemics keep happening, but pandemics are rare. And if we just look at 15 years horizon perspective, in the last 15 years, now we have two major pandemics. Like of course, COVID-19 pandemic, everyone is aware, but before COVID-19 pandemic, we rarely discussed that in 2009 and 10, like just 10 years before the COVID-19 pandemic, there was another pandemic, H1N1 swine flu, but it did not, fortunately, spread that much, or of course, then did not receive that kind of attention. But besides pandemic, besides outbreak epidemic, the new WHO classification as per international health regulation, the classification of a public health emergency of international concern. So between those pandemics, the two pandemics which we remember, there were 7 situations or 7 disease conditions which were termed as public health emergency of international concern. So PHEIC is just one stage before pandemic, and of course, pandemic situation is also a public health emergency of international concern. So disease keep happening, and entire world, and that 2 years before COVID-19 pandemic happened, 2018, WHO and other agencies together were discussing about disease X, that a disease which has a pandemic potential, nobody can predict and nobody knows what that disease would be, can happen. So even scientists did not, or nobody could have predicted that what they are talking or thinking in terms of disease X would turn reality into within like such a short span of 2 years. So their reality rarely given attention. Now, this is a slide where I want to reflect on a few points why pandemics happen. And this also has a part answer that why we need to think in terms of disease as a One Health approach. So disease outbreak or epidemics or pandemic happens, and every passing day, we are closer to the next outbreak or epidemic than the previous, than the earlier days. The reasons are that there are few things that diseases are emerging or re-emerging at a faster pace. And they are like we have a several and faster modes of transport, which essentially means that a human being can reach from one part of the world to another part of the world within less than 24 hours. And if human being can reach, a pathogen can also on the back in the sense like along with that human being can reach one part of the world. So the faster modes of transport essentially means the risk of disease transmission is far greater than earlier. And every passing day with that transport, the number of people who are traveling is also high. So we have a higher risk of outbreak, epidemic, or pandemic, which are just a geographical distribution. They are not by the severity. So several mode of transport. Second, the growing and crowded cities and the kind of living conditions which are like which facilitate the spread of pathogens. So that's a second factor. Third, the deforestation and more contact between people and wild, which essentially means the viruses or pathogens which are hidden in the forest are coming in a closer contact of the human beings. And that's why we are at a higher risk of developing, or world has a higher risk of getting a newer diseases and pathogens. In fact, if you ever wonder that why majority of new pathogens emerge from Africa, the answer is Africa is full of natural resources, forests and minerals, and that the kind of natural resource exploitation is happening, which is essentially resulting in more exposure of human beings to those pathogens which are hidden in those forests and those mines and etc. So deforestation and more contact is another factor. Then climate change. Some of these might sound like very familiar to you, but I still want to put in the perspective. The climate change, we know that if there is a global warming, climate change, the melting of glaciers, but also essentially, we know mosquitoes breed on a certain temperature or flourish on a certain temperature, 8 degree to 32 degrees Celsius, broadly speaking. But if there is a climate change, even a single or half a degree of rise in the temperature essentially means pathogen can survive or live longer or flourish in many settings. Dengue virus was reported in India in 2002 from only one state. By end 2022, all states and UTs of India had reported dengue. So it is partly due to climate change or other factors. So this is a fourth, and each of these are interlinked. Then single animal livestock operations in the large miles of area, single animal is grown. The kind of battery farming to produce meat, all of those are contributed. I'm not judging them. I'm not saying that they are right or wrong, but I'm saying that these are the human interventions which are resulting in the pathogens coming in human contact and causing diseases. The H1N1 2009 swine flu actually started from a place, a town in Mexico City, like which was a large battery farming setup. And of course, the indiscriminate and excessive use of antimicrobials, and which is resulting in antimicrobial resistance. So these are six, and these are not exhaustive lists. There are like multiple things. These are situations which are resulting in that pathogens are more likely to affect humans, and we are more likely to have a risk of developing outbreaks or having outbreaks, epidemics, and pandemics. And this has been discussed widely, extensively in the last 7 decades. Of the known pathogens, 335 pathogens which emerged, like nearly 60% had a zoonotic origin, and like around 70% had an origin from wildlife. So that's human diseases emerging from wildlife or wild forest animals. So that itself clarifies the interlinkages of human, animal, and environment, and that's what the concept of One Health we are talking about. I'll also discuss about what is the risk in the future ahead. But there is a 2007 paper which talked about pathogen transitioning from environment to animal-specific agent and then human infection agent. So this concept of exposure, transmission, and then further spread, and that's what. So ecologic pathogen pyramid, this 2007 paper, which is widely cited. So this is a natural phenomena which happens with it. The image was missing from somehow. I have already talked about linkage between environment and health, and environment is a major determinant. Healthier environment, if we improve those conditions in environment, could prevent 1/4 of a global burden of disease, which is essentially 24% of all global deaths are linked to the environment where we are living, environment-related factors, air pollution, extreme weather conditions, land degradation, water scarcity, and pollutions and plastics. So environment and health linkage is widely known. The climate change and related vulnerability, and climate change makes it vulnerable in a different senses, geographical, biological factors, which affect vectors, animals, humans. And of course, there are human health risks which are linked to the health outcomes, which are on the bottom of the slide. So, which you can see that every single organ could be affected by climate change. So if we think climate change only at the bigger level, macro level, it affects at the individual level and individual health. So we know there are a number of studies, and this is from New England Journal, which talked about global temperature increase by 1.5 degrees Celsius and human health is well established, and that's what the global climate change is expected to cause additional 250,000 deaths per year between 2030 to 2050. And I already discussed some of these points, that how climate change is going to affect the pathogen survival, spread of vector-borne diseases, and human heat-related mortality and morbidity in a mostly vulnerable section of population. Health impact of global temperature rising is on all sections, including pregnant women, and most worrying thing is that it would affect the poorest of the population, most vulnerable population. This is a paper which I often argue and use. This paper, more of a, these researchers did a estimate that if there is a global rise in the temperature between 2020 to 2070 by 2 degrees Celsius, they estimated that around 10 to 15,000 new pathogens which are confined to the wild till now would emerge. Out of those 10 to 15,000, a few, like around 1,000 to 1,500, might cause human diseases, and some of those might cause the epidemic and outbreaks. They argued that if this situation arises, majority of these pathogens would emerge from Africa and Asia, because the natural habitat and those settings, because rising population. So if climate change, which is a reality, rising temperature happens and global warming happens, the worst impact would be on Asia and Africa. The risk of pandemic and epidemics would be bigger. Pandemics are global, but risk of outbreaks and epidemics would be greater on Asia and Africa. That's why these countries need to pay attention. Entire world need to pay attention, but countries in these regions need to pay more attention. And that's why One Health, in my opinion, is an issue for entire global community, but countries such as India, countries in Asia and Africa need to invest more and pay more attention on One Health aspect. And of course, this concept you understand, but I'll just still, now we are moving to the second part, which is understanding One Health. I laid down the foundation for what makes the right background for One Health. So One Health is an approach to design and implement programs, policies, and legislation and research in which multiple sectors communicate and work together to achieve better public health outcomes. So essentially, it's a public health activity. It's an improved public health outcome with the multiple sectors. That's what WHO Regional Office definition, one of the definitions. Of course, the essence of One Health is a collaborative, multi-sectoral, and transdisciplinary approach. And it equally talks about working at the local level, subnational level, regional level, national level, global level. And goal is optimizing health outcome, recognizing the interconnections between the humans, animals, plants, and their shared environment. And what it entails or encompasses that societies, like we see sectors or disciplines involved with the environment, human, animals. What it requires is communication, collaboration, coordination, and capacity building. It requires society, individuals, rural, urban, local, national, global. And it requires, like One Health, at the essence of it is also about inclusivity. It's about addressing inequities, because anything which happens, which is much broader, has a worse impact on the poorest and most marginalized. So it's issue of equity, it's issue of access. And what you get if you do, what we will achieve by implementing One Health approach is that healthy ecosystem, healthy animals, healthy humans. So, and that's what we're striving for. It's a lofty goal, but that's the goal which we should aim for, and that's what is proposed. Is it a new concept or is it an old concept? So the idea of course, the terminology One Health is relatively new, but the foundation of One Health, like some argue, can be traced as back as long as like 300 years back. Giovanni Maria Lancisi, physician of Pope Clement XI, developed the first known strategy to control rinderpest. Of course, all of you know that rinderpest is eradicated now. So developing a strategy to eliminate or eradicate a certain disease has an origin, like which might have an impact on human. Like he was a physician to Pope. So probably the argument is that when thinking of animal and human diseases as a single end goal was conceived, could be argued as one of the starting points for One Health. Creation of first veterinary school in 1761, Rudolf Virchow, a physician, politician, philosopher, coined the term zoonosis, which again reflect the idea of human and animal interface of disease. The relation of animal to man, William Osler, father of veterinary pathology, one of the first publications was titled The Relation of Animals to Man. So there are some historical evolution. One medicine, before One Health in 1960, then wherever I talk about One Health, many of people know about Calvin Schwab. So he, the father of veterinary epidemiology, gave the idea of one medicine. So all of these contributed to evolution of One Health. And of course, there are more recent ones, and there have been high-level technical meeting and quadripartite engagements emerge a global governance structure for One Health. I'll talk about some of these in more detail. One Health become a recommended approach and political reality interministerial conference in New Delhi, which FAO, World Organization of Animal Health, WHO, and the World Bank developed joint studies. So there have been you see, I had a one slide for 300 years and then the second slide for 10 years, and that's how it has evolved. That there is more work in the last few decades than the previous years. It is big burden, and that's why number of organizations are coming together to work on or develop strategy for One Health. So this is another attempt to summarize the idea of One Health, which essentially talks about human health impact, improved health and global security, food security, disease control and prevention, improved livelihood, reduced anthropogenic effects, environmental impact, animal health impact, and the intersection of One Health. All this slide, the slide where I discussed that why epidemic, pandemics are reality, reflect that none of the one agency, none of the one organization, none of the one sector can do this thing. This requires coordination, collaboration between multiple sectors, and that's how now One Health is being fully understood. So, of course, it's a dynamic concept. And we have to think in terms of built and natural environment, ecosystem, biome, biosphere. All of majority of these slides are borrowed and the source are cited. So it's listed. It's a dynamic interaction, built a natural environment, this transdisciplinary approach. I'm repeating some of the points in different way because that's how the global understanding has evolved. Let's switch gears and now come to the One Health in South Asia and India. In the last 15 years, there have been a number of activities which have been there. One Health Association of South Asia was launched by the Wildlife Trust in India, Bangladesh, Pakistan, and Nepal. Center for Education, Advocacy, Research and Training in Kerala. National Center for Disease Control also started discussing about One Health and cooperation. Department of Biotechnology, Ministry of Science Technology came together. IDSP, Integrated Health Information Platform, is also discussing our country's first World Health Consortium was launched. I believe this institute is also playing a role in this thing. So number of actions, interventions are coming up, slowly evolving. One of the first thing on One Health concept came up around the roadmap to combat zoonotic diseases in India. Like the context was zoonotic diseases, but it's very much linked to the One Health. And for example, often in my role in WHO was universal health coverage. Now the term, a concept which came like universal health coverage terminology came much later, but countries were doing something which was very similar to universal health coverage. So if something was not known till that point of time, how can you say that that was not being done or not being done. So One Health as a concept came much recently. So whatever we cannot say that it was not being done. It was being done in a different way. So roadmap for combating zoonotic disease in India was 2008. It identified 11 zoonotic disease priority, though its major focus was on rabies, but it started in India. But interestingly, like a decade later, even when national health policy was released, there was no mention of One Health as such. But things are changing and changing for better. In 2021, Indian Journal of Medical Research by Indian Council of Medical Research published a special issue on One Health. Union Budget 2021 had a line budget item One Health, which all those who work in the government understand that having a line budget item itself is a big deal. Creating a line item itself is a challenge. Now, allocation and all of those are secondary issue, but then yes, this is what starts. Number of centers on One Health in leading institutions are being proposed or being set up. I'm sure like this, you can answer better. NIAB otherwise conducting some research on translation research and other activity, integrated public health laboratory. So One Health, and it's worth repeating, like that's what I'm saying. When a concept is new, it need to be looked, examined and broken into smaller pieces and examined from different viewpoints. So One Health include essentially zoonotic diseases, antibiotic resistance, food safety, security, vector-borne diseases, environmental health, chronic diseases, mental health. But what One Health is not like, if you say that only vector-borne diseases are One Health, like when we see them holistically, when we see them together, that makes One Health. That's the key difference. So One Health is a lot many components, but when they are considered or reflected together, a vector-borne disease preventive or control measure does not automatically become One Health intervention unless our thinking in that direction that it requires collaboration, it requires different work. So piece makes the whole complete, but piece itself is not the whole sort of like approach. This zoonotic disease, human animal environmental interface, I would not take much of the time, but this is widely known that what happens and how the disease is spread, and how some of these are the real examples, from rabies to the dengue. They spread only from animal, like initially the virus pathogen exists animal, from animal or human, animal to human, and then only for human. So different approaches. What has happened in the recent period, like a tripartite guide to address zoonotic diseases in country, like this came from Food and Agriculture Organization, World Organization for Animal Health, and then World Health Organization. This tripartite agreement talked about multi-sectoral One Health coordination mechanism, strategic planning, surveillance, information sharing. And these are the activities or interventions which are required: joint risk assessment for zoonotic diseases, risk reduction, risk communication, community engagement, and of course, workforce development. So we talked about what it is, what it takes, and then what should be done. And that's what the tripartite agreement. India had a roadmap to combat zoonotic diseases. I already discussed the national level multidisciplinary endeavor on research, capacity building. So a lot of things have happened. Active technical support of 13 national and international institutions. This was envisaged for last 15 years. And I think that makes a good platform on which future One Health intervention can be built upon, the ongoing discussion on One Health mission, etc. So there is some background work, some learning, some experience which can be utilized. And what it discussed, something similar that there have been a committee, there have been intersectoral coordination. We can argue whether sufficient has been done or not, but there have been some thinking in that direction, which we can build upon. Component of economic costs, there are economic costs of zoonotic diseases, outbreaks, and that's what makes that investment in One Health very efficient, that there are many direct and indirect costs associated with diseases to human, animal, and environmental degradation. So every investment on One Health is worth doing it. We know about antimicrobial resistance and other aspects of how it happens at global level. Epidemiology of antimicrobial resistance, I'll not try to explain this complex schematic, and this is a separate topic, but I just want to put on the table that antimicrobial resistance is one health issue. And it comes in a different ways. Food, like we know, the indiscriminate or excessive use of antimicrobials, antibiotics in the poultry animals actually percolate to the humans, and then it results in a antimicrobial resistance. So the use or interventions in a farming, animal husbandry, etc., indirectly affect human health and affect antimicrobial resistance. So they are very much interlinked. So what is required? Of course, integrated surveillance and antimicrobial resistance and related aspects. One health approach to detect emerging threats, and that's what globally being discussed. Like my talks are really complete. I did some work on COVID-19, so really complete without like learning from COVID-19 pandemic, and there are learning for pandemic which should be understood that pandemic or disease outbreak. Rather, I would go outbreaks, epidemics are one health issue, and efficient one health surveillance is needed if we want to like get started. And no dialogue on one health should be complete without integrated one health surveillance. There is a need for developing an ambitious roadmap for each step of pandemic response, and need for going beyond past and current one health project and strategic plan, but actually much bigger, large scale collaborative implementation approaches are needed. Pandemic preparedness and early detection should structure one health action plan. Predefined one health structure or task force should be part of crisis management, use all diagnosis. So future epidemic outbreak response need to have a one health approach rather than a sector specific approach. And some of this is from this viewpoint, which was published in Lancet late last year, October 2022. India has like some of the routine surveillance mechanisms. I think those surveillance mechanisms need to be integrated, and there is a lot of some thinking going on onto it as one health surveillance in India. We talked about tripartite agreement, but now there is quadripartite memorandum of understanding signed for new era of one health collaboration. And these global, one may ask that what is the relevance of such kind of broad scale global memorandum of understanding or like agreement for smaller settings? Actually, they provide a very sound logical background to start the dialogue. They are very useful for national level policy dialogue and seeking funding within the government. So this MOE, of course, agencies are listed there: FAO, World Organization for Animal Health, WHO, and UN Environment Program. So the agencies and global agencies are coming together to work in this direction. And these agencies have a one health joint plan of action, which can be used locally for countries and institutions. Some argue, and I subscribe to that idea, that like though we cannot prevent every outbreak or epidemic, but we can definitely reduce the risk of such outbreak epidemic, and we can definitely mitigate their impact. So in Kerala, we keep hearing about Nipah, but Nipah virus outbreaks at least 3-4 times. Nobody would argue that they can be completely stopped, but definitely their impact is mitigated when we have a better approach, when we have improved surveillance, integrated approach, Q fever. And so one health, there are many arguments and which are fully proved, can help in reducing the disease outbreak, but their impact also. But this is all like not very something that this is so easy, so but it's still not being done. There are challenges in one health approach. Challenges is like bringing sectors together. So the challenges related to institutional challenges, the policy, visibility, engagement, conflicting departmental priorities, and limited institutional and human health work or institutional and workforce capacity, which need to be tackled. And then there are technical challenges related to infrastructure, resources, knowledge gap, surveillance, and contextual challenges of complex disease governance system, inadequate implementation of current policies. Sometimes policies are formed inadequate implementation. So there are challenges, but those challenges will be tackled and overcome only when we start thinking the direction. This is a customary slide in a sense that I should not be talking about the need for One Health in India. There is a need for, like, that's what the entire presentation was all about. But it is gaining significance. Human expansion to new geographical areas, close contacts. We know the diseases are emerging, zoonotic animal to man origin, environmental disruption, international travel and trade, viruses. So all of these factors, like India also need not only like within country, but need to showcase to the rest of the world, especially low and middle income countries, because I talked about that majority of future disease outbreak epidemic would happen in Asia and Africa, and countries such as India need to showcase our capacity, but also capability and financial resources. So we need to take lead in this area. There is the National One Health Roadmap being already framework available. The objective, we need to develop a National One Health Roadmap based on learning or pilot project implementation. This is the roadmap looks like. So a lot of thinking has gone into those directions. A consortium launched by, I believe, NIAB play a major role in this consortium, which now has, I think, 26 institutions. G20 had a focus on One Health. So One Health has gained the momentum. I think when in 2023, when we are commemorating World One Health Day, we are definitely in better position, better prepared than all previous World One Health Day. 7 recommendation of G20 committee, which can also be utilized for various One Health related aspects, raise awareness, advocacy about One Health, identify gaps and opportunity, improve One Health governance, support One Health funding and investment, use the One Health joint action plan for joint plan of action as a blueprint for action, implement the One Health approach in all relevant policies, facilitate One Health research, knowledge and capacity. So this is coming from G20 Health Working Group or high-level expert panel. I already highlighted this slide. I'm just bringing this that it is very much linked to that perspective. It is not without, or the benefits are not restricted to health. There are financial, economic benefits. There are benefits in terms of eradication of diseases. There are global solutions, interventions which are available, prevention of outbreaks, and of course it requires education and awareness. So there are many actions, many areas required, but it's possible. So to conclude, we started with the relevance of One Health, the theoretical part. We discussed about One Health. Then we moved to what is happening currently globally in national level. We briefly discussed some of the challenges. So to conclude, I would say One Health is the only way to prepare and respond to epidemic, pandemic. Without doubt, like we can underline the only way, like other individual sector cannot work on it. So One Health approach need to be followed to be prepared for epidemic, pandemic of the future. One Health is the efficient and optimal approach for optimal health for human, animals, environment, and planet. This all is being recognized, but there is insufficient action at various levels. And now we have a theoretical know-how. It's time to implement. It's time to act through a coordinated, collaborative way at all levels. One Health approach can prevent outbreaks, improve food safety, security. It benefits at individual level. So the top level or broader level policy action benefits at the individual level. So Joshua Lederberg, he's Nobel laureate, he said the future of humanity and microbes likely will unfold as episode of suspense thriller that could be titled Our Weight, Their Genes. Our weight will determine that how well we implement One Health approach. The microbes are changing every passing moment with changing their genes. So it's like a suspense thriller of our weight versus their genes. Let's see how we respond to it. Thank you very much. Thank you very much, sir, for such informative and wonderful talk. You can ask me questions if you can. Sure.
I was more interested in your publication and how is it localized only in UW or is it for the India? Is it the angle of NHS that plays a major role for this? What are you doing?
Sorry, I missed the first part. About my foundation. Okay, sure. Okay. The foundation, I worked with WHO for 15 years at different level and different agencies. Then I thought, let's do something more concrete at the ground. So I have set up this foundation for people-centric health systems. We work in three broad areas. We work in policy and strategy, where we support government and different agencies in developing various documents and implement various strategies. Second focus area is health communication. I strongly believe, especially after my scientific writing in newspapers, the mainstream media, that unless we can communicate science to general public as readers, we are not going to achieve what we want to achieve. Like One Health, the concept, in these concepts, we should be able to break. Like I've not done that because this is a more erudite gathering, but we should be able to pass on those concepts to a general public. And that's why I'm a strong believer in health communication and public communication on health. So that's the second vertical. Third, we deliver primary healthcare services. We implement some of the global concept idea that we keep talking at the policy level, that people need to have a primary healthcare. But we often do not explain that what is how to implement at ground level. So we do those three things: policy, strategy, health communication, primary healthcare. But within policy strategy, one of the core vertical focus area of our work is One Health, climate change, and antimicrobial resistance. In fact, former director of National Center for Disease Control, Dr. Sujit Singh, has joined us, and he will be started working with us. So where we are going to focus upon working with the various agencies, including Principal Scientific Advisor's Office, One Health, but we are also in discussion with the World Health Organization Regional Office for CRO, South Asia, on Southeast Asia, on having a South Asia specific collaborative work. So we will do what are the global mandates, but we will support through the technical expertise. And this is a new organization. We want to have a focus work. So more especially on this area, we will focus upon One Health, climate change, working with different government agencies, different stakeholders, including like if Madam Dr. Taru Sharma agree that with this institute, we will also have some collaborative engagement and work. Thank you. So first of all, like this, my opinion is entirely my own, not related to WHO. Second part is that I have done fairly long work. My first engagement with WHO was on the vaccines only. Like I started with WHO working on vaccines 2008 to 13, and COVID-19 also public policy related work on vaccines. So I've studied these vaccines and my work is with Dr. Jagandeep Kang, who is also renowned expert on vaccines. Now, your question is like require much detail and nuanced response, which will take a longer time. But let me summarize this aspect. Like first principle, we remember that everything has vaccines have a risk, and vaccines have a benefit. So any intervention, human intervention, even medicines which are given, are not without risk. Even water can cause some adverse reaction in some individuals. So even COVID-19 vaccines have some risk associated. They were administered in COVID-19 pandemic period because the benefit was far greater. We knew that unexposed, like people who do not have a past infection with like SARS-CoV-2 in the beginning of 2020 was novel virus, but slowly by 2021, 2022, majority of population were exposed. What we knew that first infection, initial infection or first infection could be severe. And then if we vaccinate people, the risk of infection or risk of severe outcome is low. So every single vaccine, that's my opinion, which has been licensed has far greater benefit, had a far greater benefit during the period of pandemic when the population was not exposed. But each of these vaccines has a risk associated, and cardiovascular, cardiac health, cardiomyopathy or related risks were associated with mRNA-based vaccines. Some blood coagulation related risks were associated with the viral vector vaccine. All other vaccine allergic reaction like pain and local side. So let's keep aside minor health issues, but the adverse responses, to the major adverse responses, and they were also dependent upon age of the certain individual. So the benefit of most of the vaccine, because risk was highest, risk of severe disease and mortality was highest as the age increased. So someone who's 60 plus has a very high risk in comparison to someone 20. When it comes to risk factors, it was found that the adverse reactions were usually all higher in younger age group. So the benefit of COVID-19 vaccine was in all age groups, but the benefit risk ratio was far greater for older population. And I'm talking about broadly all vaccines, and I'll come to specific vaccines. But the risk benefit was relatively less in younger, healthier population, and usually in a population which is younger than 18 years, the benefits, even though benefits were there in those population, but risk was also high in this population. So viral vector vaccine, such as Covishield in India or Oxford AstraZeneca vaccine, was never licensed for younger than 18 years because they had a high risk. Now, cardiac adverse events have been associated with mRNA-based vaccine and they are also setting specific, like systems which has a high vaccine adverse event response surveillance system have not found much of the difference, like blood coagulation related with viral vector vaccine, but definitely reported in the European setting. Cardiac adverse events were reported with mainly mRNA-based vaccine. So they were adverse events, but benefits always outweigh this. Now coming to the second part, that was the COVID-19 pandemic period. But now when the pandemic is over, the risk of COVID-19 itself is low. So the benefit COVID-19 risk is low, which essentially means benefit of COVID-19 vaccine limited. And that's why there is no consensus on their use in the time ahead. Like they are not, COVID-19 vaccines are not the kind of vaccines, the flu vaccine, where we expect that they would be used. So first point, and this was the longest point, I already warned you earlier, the benefit was there, risk was also there, but benefit was far greater, and that's why those vaccines were used. That's part one. Viral vector vaccines also, some risk was there. That risk has not been reported from India. The related point to often argument which people make that, okay, the cardiac people, even from India, there are reports, and even very recently someone said that people are dying after COVID-19, and some argue that they were also vaccinated because sudden cardiac arrest, playing, dancing, gym, And some argue that these are happening due to COVID-19 vaccine. So the first of all, epidemiological data say that globally, during the period of COVID-19, in fact, like the cardiac deaths had declined rather than there was a rise. So it's not correct information that COVID resulted in increased cardiac event incident. During that period, the number declined. Now, why people are dying? At least for India, for Indian population, we cannot say that it's the mRNA vaccine because mRNA vaccine has not been used in India. So which is a positive side. Otherwise, people would have been argued, at least in India, that this is mRNA vaccine which is causing the death. So the cardiac arrest or sudden cardiac deaths are not linked to COVID-19. And then even very recently, Lancet published a study in which, like very small sample size, they have found that even if there is a risk of sudden cardiac arrest in certain population, like there is not risk, there is some myocardial changes at a microvascular level, but those changes last only for 1 year. So if someone dies after like 1 year or 2 year of COVID or any vaccination, it cannot be attributed to those vaccines. Third part is that COVID risk is already over. Like COVID is not like flu. People often, or COVID vaccines are not like a flu either, because flu viruses keep changing very frequently every year. So their mutation is very different, and then people can get infected. But SARS-CoV-2 is changing, but those changes are very minute and unlikely to affect. Like we do not really know that whether we will ever need a COVID-19 vaccine in future. We do not know whether if we ever would need, whether it would be 2 year, 5 year, or only high risk population. So to summarize these broader points, because I did not want to answer in a simple short term that this is not associated or associated. First point is that all COVID-19 vaccine has some form of risk, but those risks are minimal. Second, mRNA-based vaccine have been reported to have that, like in a public discourse have been reported, but there is no scientific evidence that their risk is very high. Some certain populations have reported that risk is very low. Third is viral vector vaccines are also associated with the blood coagulation related disorder risk. Fourth is that those vaccines are very unlikely to be used in the future, because what we know that those were the first generation vaccines. What will be used in the future will be a second generation, much improved vaccine, a different version, if at all. And final, my sense of working in COVID-19 is that healthy adults would never need COVID-19 vaccine. So COVID-19 pandemic period, our approach was different in that now post-pandemic period, those vaccines, even if they have a risk, the benefit has reduced, so we should not use them that frequently. It's not fully answered, but I can deliver a 1 hour talk on this topic. I have delivered different places. Yeah. Well, I fully agree to your point. So, okay, but this is part of the evolutionary approach in public policy making. If we want to have a much broader perspective, like One Health approach, we are laying down the principles. Like globally, what is happening right now, the principle that this will benefit everyone. But what you are saying, a second part, that it does not capture the fully. For example, if we start talking about rabies control in any setup, that becomes a specific example. But then someone can say that, okay, this is what is applicable for rabies is not applicable for other diseases. But I got your point fully. It is currently at the much broader label without specific nitty-gritty, and that kind of work need to be done. That is one area I think we need to have understand. Other area which need to be discussed, or which need to be that uh, there is not sufficient stakeholder analysis, that what the entire landscape analysis, that what is happening by different sectors to control a certain diseases, or to do different interventions. So when we know, when all of this, like animal, human, environmental sectors know what is being done in different areas, entire mapping is there, then only we will understand that how they can be connected. So currently, like this definitely is a much broader level and need to be brought to the specific level. Uh, I agree on that part. Like the serious adverse events, like, but there are two things. One is the non-serious or minor adverse events. They definitely are less reported. Major or serious adverse events are also insufficiently reported, but they are relatively better reported. You cannot hide. But more important thing is that, of course, we want an ideal system where everything is well reported. But there are a certain thing which is called trend. We definitely know that what is the trend of those events in those settings. In India, like I would not argue that everything was reported, but the Indian government collected data. It's not available in the public domain. There were deaths following, which were attributable to COVID-19 vaccines also, which are part of the government system reported. So I have no answer that what can be done to improve this thing, but it has everything has a scope of better reporting, but it was documented reported. But key point is that a death or major serious adverse event is unlikely to go unreported. If if India has administered 200 crore vaccine shots, or 100 crore around population vaccinated, if there were major change after vaccination, it could not have gone unnoticed. Like there were deaths and there were serious adverse events, but they were within, like, if you vaccinate 100 crore people, there are even 1 in a million uh, adverse events, which I believe is acceptable, which could essentially mean means 1,000 serious adverse events would be reported. So it's always risk and benefit. The moment somebody starts saying that vaccines have no harmful effect, that person is wrong. Vaccines can have a potential harm to individual which we do not know. We should use vaccine assess knowing that harm and examining the benefit. For example, right now it does not make much rational to say that any broader group should be vaccinated with COVID-19 vaccine, because we know they can cause harm. We know any vaccine can cause harm. We know the safest of the vaccine can lead to adverse events. So, and regarding improving the reporting system, any reporting system, be it for vaccines or like any health data or any system report, it's a system issue. But we should definitely strive for improving that. Mhm. I think it's an entire spectrum that in the ideal world, we would like a good quality data collection, that analysis of that data, and then sharing. But in the real world, we know that if there is an effort to collect the data, which happened in the COVID-19, like INSACOG is an example of genomic surveillance and collecting that data, then analysis relatively better than before pandemic period, that analysis was used for decision making. The weakest link in this process is sharing. Of course, it should be shared. And in fact, what we heard from different sources that it was like not even shared within the government institutions, but logistically. But these are the policy issues which we cannot change overnight, or not in anyone's hand sitting in this room or standing in this room. But ideally, like these are the step-by-step processes. We need to improve each of those. And the approach, in my opinion, in public health practice is that it should be wherever we are, we should strive to improve a little better than, like a drastic better is ideal, but I do not think ideal is something which we can expect every single time. But realistically, strive for wherever we are, let's do better than that.
So, you mentioned about disease. I'm just curious about how is the disease predicted, because we live on the earth with many potential pathogens which can outbreak anytime. So how is the next pandemic with regard to disease expedition?
Nobody can predict the next pandemic. So disease they just they brought in some of the experts in 2018. They started thinking that which potential pathogen could cause the disease, and then they had a list of the diseases. But then alongside, what happened? One of the side intervention with that around that was Coalition for Epidemic Preparedness and Investment. So CEPI was one global institution was created, which was thinking in terms of investment on vaccines and research on those potential pathogens. So if in COVID-19 pandemic, if we could have a better response and accelerated work on vaccines and some of the research and development, it was partly due to the world global community had reflected that there could be a potential disease. So they created a CEPI, a separate mechanism of coalition which supported research investment. And now counterfactual, or in the words, like we do not know if whether CEPI would have not have been, what would have been different scenario. The current assumption, and we can fairly confidently say that because that thinking had gone into thinking about a potential disease which can cause a pandemic, the thinking resulted in some institutional framework and some funding to support the vaccine research and drug research. Those mechanisms could be activated for SARS-CoV-2 or COVID-19 research, and that way, in a way, contributed to better response. So these are the approaches. So like nobody can predict. Like I must say, one Australian virologist, evolutionary virologist. She was one of those few scientists who did an entire full genomic sequencing of SARS-CoV-2. In May 2020, like 5 months into the pandemic, after the emergence of virus, she was asked what would be the pattern of COVID-19 pandemic. And she initially responded in May 2020 that I'm a virologist, I'm not in the prediction business. But when Delta wave spread across the world, a year later, she was again asked the same question that now this is playing havoc in the world. What do you think? Do you want to reflect again? So she said that she had studied many viruses, but she did not know, like she had not seen, and coronavirus or SARS-CoV-2, coronaviruses are not new to the world. Like, so in a sense, SARS-CoV-2 was a novel virus, but it was not a novel family of viruses. It's like 1950s, the coronavirus was known, and there are 7 coronaviruses. So it was not a new virus family, but a new subtype of virus of that thing. So she predicted that what was unique about SARS-CoV-2 is mutated at much faster rate, and the mutation resulted in more severe, like higher transmission and severe disease in comparison of other viruses. So that is the only unique thing. She also predicted a year later in 2021, he said that at the pace which this virus has mutated, maybe in the 5 year or 10 year down the lane, the SARS-CoV-2 genomic sequence of relevance could be very different from the what it originally was identified. And that point of time, all the vaccines which we are using may not be useful. Like the future COVID-19 vaccine, if ever happens, would be completely different from these vaccines, whether they will be multivalent, polyvalent, or a completely different. That's the kind of evolution we see. So prediction is very different. Disease X, nobody predicted. They simply gave a name disease X, that a potential disease which could happen, and how should we prepare. So it's not about the pathogen, but it's more about the preparedness, that how well should we prepare about the epidemic, outbreak, of pandemic due to any pathogen. So not about the pathogen specific, but the preparedness itself.
So I have, so you mentioned about the re-emergence of eradicated diseases. So what is your view or an policy on initiating research on eradicated diseases? How much we
So okay, if I said, then I must have said this wrongly. I did not say that any eradicated disease can re-emerge. But I talked about emergence or re-emergence of diseases. But like only two diseases have been eradicated: rinderpest in animals and smallpox in humans. And there's no discussion, to my knowledge, going on about their re-emergence, because we are fairly confident that smallpox has been eradicated. And whatever two samples are, like places they have been stored viruses. In today's time, that is of limited relevance. When smallpox virus genome is fully known, it can be created in the lab. So the risks and those settings are definitely there. But to my knowledge, there is no global discourse on eradicated diseases. But emergence or re-emergence of diseases, like this is One Health, an entire global community for infection prevention, is about emergence or re-emergence of diseases.
And the second one you have shown us, a table where with Nipah in Kerala, where 18 positive and 17 dead. But yesterday I was watching TV and I saw a ceremony where Minister was felicitating from the covered
That I think that was for a previous, like 27-18, like there were other. These are two numbers, 23 positive and 21 dead in a previous, like 2017-18. Not in this one. This outbreak, I think one or two.
Thank you, sir. So, as you mentioned that in our
Okay, so South Asia and Africa. So because of natural habitat, because of insufficient preparedness and response, these are the answers. Because the factors, which if you recall, I outlined the factors. The factors are like climate change, deforestation, natural resources. But then, okay, so the deforestation or all of those things, European setting is very different. Like happening in Asia and Africa are more likely. I'm not saying that it will not happen in other settings. This is just a comparative.
My question is related to the disease that is participant of 7 countries now, and so we talk a lot about COVID-19. So now, the government has taken this remote state. terms of One Health, as the global one, so in this case, what is the problem for and how to go to
So thank you very much, sir. I'm not expert on TB, but I'll answer some broader aspects. One is the TB Mukt Bharat. Essentially, they are talking about 80% reduction in the infection and 90% reduction in death. So TB Mukt is, of course, is not about zero TB or this thing. So certain targets have been set. Globally, this target is for 2030, but Indian government say that it will achieve by 2025, which in my opinion is unlikely or impossible, as most of us understand. So 80% reduction and 90% reduction in death is unlikely by 2025. In the future, it may or may not be. That's part one. Second is the like Indian government is exploring additional steps. Second, of course, your point is true that during the COVID-19 pandemic period, all the services were deteriorated, and that 2020 was the for which data is available. We know there was an actual rise in the cases and deaths across the world, in India, in tuberculosis, which happened after 10 years. Like the last 10 years, there was continuous decline, but 2020 there was rise. Third is there is definitely more need to be done. There are some new bedaquiline, other treatments. The new TB drugs were not becoming available. It's only recently some new TB drugs are available. Fourth is big challenges that Mycobacterium bovis and others, but 1/3 of Indian population is already exposed or have a Mycobacterium tuberculosis in their body. Like tuberculosis prevalence in countries, 1/3 of adult population is affected. So anytime, like you can, of course, individual can pass on to other family members. So by the time you turn adult or anyone is already exposed, so if you become malnourished or your immunocompromised, you are likely to develop TB. So that's a challenge in the country. There are new evidence, a recent ration study which talks about nutrition, etc. Improved nutrition can play as much as a role as the TB treatment. So I really do not have answer, and I'm not expert, as I said earlier, whether how India can achieve. But Indian government is also exploring some strategy, additional strategy, like a nutrition program support to this TB patient, which is not sufficiently implemented. But one of the other things which they are going to do is the BCG vaccination of adult population. Currently, they are going to roll out as a pilot mode that I believe in 15 Indian states and selected districts, adults will be administered BCG vaccine. And then this will be a case control study, and then they will see that what is the impact of it. Because there are 16 countries across the world which administer BCG vaccine in adult population. Like these, I'm talking about the TB endemic countries and some other countries which give a BCG vaccination to adult population. So Indian government is also going to explore those strategies. Finally, of course, governments have a certain approach to say or do things that we will achieve. But to me, whether that target achieved is important but not super important. To me, like, are we going in the right direction? The trend is that are we making dents from wherever we are? And if we do certain strategies, there is no strategy. So I really do not know how there will be major drastic change. No proven strategy known. So I really do not know how major drastic change would be achieved.
Okay, thank you very much, sir.
So, thank you very much for giving your presentation. Everyone on this video. I really appreciate what you're talking about, the culture, your work, and all that. Personally,
Yes, sure. Okay, so your question is about whether the mechanism for surveillance of. Yeah, so till now, the overall disease surveillance was limited or weak. Like it started, IDS integrated disease surveillance program started in 2004, but now they have moved to integrated health information platform, which is under National Center for Disease Control. The advantage of that platform is that it can be adapted by multiple factors. The user interface is so easy, like and the login ID can be provided individual, like so multiple factors can be brought in together, and that kind of platform has been created. But to my knowledge, it's not sufficiently implemented.
Yeah, so I think I was in my point. Maybe that is one place which because the system works very well.
Right.
So in many officers and balance so like that owners and all that. What happens when people like not but this kind of so
Mhm. I think it's part of the overall thinking. Yeah, it's a part of overall. So I've not seen the final document which like One Health Mission will be talking about, but I had a discussion with them. Yeah. Mhm. Agree. Okay, so we'll take note of that point and we will discuss it.
Thank you very much.
I'm from you. Okay. It will go to your room.
Thank you for it.
Thanks, sir. Thank you, ma'am. If you have the event organizing committee, that is I would like to thank our successful Lahariya for accepting our invitation and for being here with us today on this special occasion. Thank you, sir, for enlightening our audience about various aspects of One Health. I would also like to thank our director, ma'am, for her constant support, members of the organizing committee, all scientists, NIB staffs, and all students for their presence. I would request all to please join for a cup of tea outside auditorium after a quick group picture near the podium. Thank you very much.